Welcome to the Medical Muse podcast. Discover the humanistic aspects of physicians and scientists as they describe their career paths and any advice they have for current medical students. Each episode, we interview a new guest and discuss the future of the field. This is the Medical Muse.
Hey everyone, welcome to the show. We have Dr. Ivan joining us today. Dr. Ivan is a pediatric emergency medicine physician who completed medical school in Israel, general pediatrics residency at Baystate Children's Hospital in Massachusetts, and Pediatric Emergency Medicine Fellowship at UPMC's Children's Hospital in Pittsburgh. Dr. Ivan currently works in the emergency department for Advent Health for Children in Orlando and teaches many medical students, physician's assistant students, and pediatric and emergency medicine and family medicine residents. Welcome to the show, Dr. Ivan.
Thank you, guys. Thank you very much for having me.
So, Dr. Ivan, want to go ahead and tell the audience and us a little bit about yourself? Where did you grow up?
So thanks again for having me, guys. I like your podcast. I've listened to it many times. And, you know, this is a very big deal to do this as medical students between how busy you are and everything. So really impressive. Thanks for having me on the show. And yeah, I'll tell you a little bit. I was born and raised in Israel. Like everybody else in Israel, I joined the military when I finished high school. And when I finished the military service, I came to the US just to travel, really. And I ended up staying for college. I went to college at Northeastern University in Boston, and then went to grad school in New York, studying biomedical sciences at Touro College. Then I went back to my home country to do medical school, and actually completed an American medical school program where you take the USMLE and you only get an American license. And so I came back to the US for residency in general pediatrics, and then continued for fellowship in pediatric emergency medicine, like you said.
Okay, great.
A lot of back and forth.
I have a question about the military service. When you were in the military, did you learn any skills or anything that kind of helped you as a medical student or even as a doctor, like maybe discipline or anything like that?
That's a good question. So I was not a paramedic in the military, but as a infantry soldier, you spend a week learning the very, very basics, such as hemorrhage control, and I forget what else was there, CPR. So that's common for all soldiers in the Israeli army, at least when I was. I was not a paramedic. Those of us who became paramedics spent several months in a course and obviously deal with acute care.
How many years did you serve in the military?
So back when I was a soldier, I think it has changed since, but it's mandatory 3-year service for men.
Oh,
yeah.
Okay. So we have a common friend, one of our friends, Charlie. He tells us that you're quite into music. How did that become a part of your life?
So yeah, Charlie was my scribe, great guy. And I started playing music when I was 16. I had a bunch of friends who played the guitar. And, you know, when you have friends who play the guitar, you start playing music as well. So I picked up the bass guitar. That was my very first instrument. And then we started a band. And when you play in a band, you often pick up a lot of other instruments and you become very passionate about music. As teenagers, it was a significant amount of time what I did. And then basically in college, in med school, in residency, I was always part of a band. We always found people to play with. And I picked up the drums and the electric guitar and the ukulele and the piano, and just a lot of fun. I actually came across a study that showed that people who practice music while studying, specifically science, tend to do better. It had the whole theory behind it, left brain, right brain. So when you study sciences, you use, I think, the left side of the brain. And it is recommended that when you take a break from studying, you use the right side of the brain. So do something artistic. So I used to for step one, I used to study for hours, play the guitar, study a little more. I don't know, it worked out, so I did okay. So
interesting. Cool. And do you have a favorite to play now?
My favorite instrument has always been the bass guitar.
Okay.
few years ago I picked up sorry, few years ago I picked up the ukulele, which is also a great instrument. And now the kids play, so play together.
That's wonderful. So what went into your decision to become a doctor, and describe some of your journey through becoming a doctor, through residency, and so on.
Um, I think my first inspiration, it sounds very corny, but my first inspiration to be a doctor and specifically a pediatrician was my pediatrician, who unfortunately died a year ago from cancer. But his name was Dr. Farkash. He was my pediatrician as a kid, and he was the nicest, funniest guy I've ever met. And I remember going to the pediatrician as a child. It was a very good experience. Um, and I was always kind of fascinated by him. And as I grew up, middle school, high school, I was really into sciences. In Israel, like in college in the US, in high school, you have to major and minor. So I majored in chemistry. And my other sort of hobby or something I used to do very much as a kid to a teenager to pay for all my guitars and my expensive hobbies, I used to do a lot of babysitting. And I've always been very fun with kids. I've always been very good with kids. I like spending time with kids. Um, and somewhere around, my late teen years, I figured that if I'm a doctor, I can combine my passion for science and biology with kids if I become a pediatrician. So I actually was one of those lucky people who knew I wanted to be a pediatrician. So for me, it was never about I want to be a doctor. I wanted to be a pediatrician at a very, very early age.
That's the exact opposite experience most kids have when they go to the doctor. They're usually terrified and crying and screaming. And I know I didn't like it.
And just
That's
stressed
correct.
out, yeah.
Yeah, and I don't blame them. When I look in their ears, it's always very painful, and they're already feeling unwell to begin with. So it's never a great day.
What
Mhm.
types of skills do you use when you're in the pediatric ER, trying to calm down a child that's probably very stressed out and just doesn't want to be there? What types of skills do you use to calm them down and to work with them?
That's a good question. I think the most important skill or sort of characteristic to have is you should be calm. So I teach always the resident. I always teach the residents and the medical students. You got to be calm, cool, and collected when you go into that room. Certainly, if the kid is very ill, you got to be very cool and collected because if you start stressing out the nurses, the residents, it's all going to be downhill from there. That's number one. And number two, for the sake of the child's anxiety and the parent's anxiety, if the kid is very ill appearing, if the kid is in distress, I think my demeanor and oftentimes the parent's demeanor makes a very, very big difference. So
Mhm.
I think it's something you're not necessarily born with, but you kind of have to train yourself, and it comes with time. You see very sick kids, you walk into the room, and the last thing you want to do is look stressed or look worried.
And did
So
you spend some years practicing as a pediatrician first before you pursued the fellowship in
I
pediatric?
did not. I did not actually. No, I did not. So very early in medical school, when I first rotated through the pediatric emergency department, I knew once I'm done with residency, I want to do pediatric emergency medicine. So the decision to be a pediatrician was when I was a teenager. The decision to be a pediatric emergency doctor was in second or third year of med school.
Okay. And
Yeah.
was your schooling very similar, like pretty much 2 years of classroom work and then 2 years of clinical rotations?
Yeah, so the medical school I went to in Israel is actually an American program because I had an undergraduate degree already from the US. So I actually took the MCAT, and it was an American program where we do 2 years in the classroom, just like you guys, and then clinical years mostly in hospitals in Israel and some in the US.
Oh,
Is
cool.
there a reason why you decided to go abroad for your medical education as opposed to doing it at home? And well, I mean, here in the US?
Yeah, so it's a good question. So I was living in Boston and in New York at the time, right? And I took the MCAT back then. The MCAT was out of 45 points, so the max And I did well on chemistry. I did well on biology. I did not do very well in the English. So the options were to try to apply. I applied to some U.S. schools and did not get in. So I applied to some schools in the Caribbean, and I did get in. But I applied to some American schools abroad, and it just made sense to go back to Israel, where my parents are and my family is, and I can live there. It's my home country, and kind of go to an American school, which is what I wanted, what I needed. It worked out for everybody. It also was a little cheaper, just a little bit cheaper.
That's
Yeah.
definitely a bonus.
Not a whole lot, but a little bit.
So, where along the way did you get your, or not get, but find your wife and have kids? And how did you balance that?
So that's another great question. You guys have great questions. So my wife and I actually met during my military service, and she was actually the reason I came to the U.S. I came to the U.S. to travel with her, meet her parents. She's originally from Boston, which is why I ended up in Boston and going to college at Northeastern University in Boston. And so we got married, and we actually had our first child a month before I took the MCAT.
Oh, wow. Okay.
Wow.
Yeah. How I did not fail that exam is a miracle. Yeah.
Yeah. And you made it through somehow.
And we made it through. And then when she was 8 or 9 months, we moved to New York for grad school. I should tell you guys, the grad school I went to, so the med school I went to was actually an MSMD program, where you spend 1 year in New York getting a master's in biomedical sciences. And then, assuming you pass, you continue to the American Medical School in Israel and get your MD. So it's a 5-year MSMD program. So we moved to New York, Long Island, and got my master's degree there, passed, went back to my home country with the wife and one kid. And then our second daughter was born a month before I took step one. Again, another miracle.
Wow.
Somehow I did not fail.
Yeah.
And then when we moved to the US, right before residency, our third one was born. I was a fifth year student right before I started residency. So I started residency with 3 kids, and it was very, very challenging. My advice to you guys, or whoever listens to us, and that's probably good for everybody, but certainly if you're going into medicine, choose your spouse wisely. Because I could not have done everything I've done, without the absolute and unconditional support of my wife. She took care of the kids, took care of the house. I was studying day and night in residency. I was gone many hours in fellowship, even more so. So, yeah, she's a very big part of my success.
That's
Do you have
amazing.
any advice for medical students or residents that are mothers now, and how to juggle all the different things that are trying to take up their time and managing a family?
Yeah, so yeah, so a lot of time I interview students applying for our residency program, and I always tell them, you're investing in your career. Apply to the biggest, most academic residency and fellowship programs, but if you can be near family, make that a priority. I think it's very, very challenging to have kids as a resident without having some kind of support other than your spouse, your parents, your in-laws, family who lives in town who can help out. Makes a big difference.
That's incredible. Coming back to the topic of pediatric emergency medicine versus adult emergency medicine, what are other key differences that many people don't usually know about when dealing with those two different categories? Do you mind shedding some light on that?
Really, there is no adult emergency medicine. So when you go to residency in emergency medicine, you spend at least 3 months in the pediatric emergency department. And I think emergency medicine physicians often get offended by us saying that they're really not adult doctors. They are general emergency physicians. And by far, majority of kids in the US get seen in the community emergency departments by general emergency physicians.
I see.
The difference when you do a fellowship, and get certified in pediatric emergency medicine is you can work in a children's hospital in a pediatric emergency department, which often means you only see kids, and the differences are huge. I'll give you an example. If a 60-year-old male, or even a 50-year-old male, or even a 40-year-old male comes to the ER with chest pain, you're going to go down that MI. You're gonna make you better make sure this guy does not have is not having an MI, right? When I see a 16-year-old with a healthy average 16-year-old coming with chest pain, MI is the last thing on my mind, right? So number one, I know because I'm a pediatric emergency doctor that literally 1 in 1,000 kids, and that has been studied, 1 in 1,000 kids coming to the pediatric emergency department with chest pain actually has something wrong with their heart or their lungs. And I know that I should be a lot more worried about a pneumothorax, which is a lot more common than an MI in a 16-year-old. I know that I maybe need to worry about myocarditis because that is a lot more common than an MI in a 16-year-old. So I think the biggest difference is to know the basic epidemiology. What's the most common cause of chest pain in a 16-year-old? That is something I know very well. And it's the same for abdominal pain or vomiting, for example. If I asked you guys what is the most common cause of surgical abdomen in kids, what would you say?
Appendicitis.
Appendicitis is absolutely correct. But the good answer, Danielle, the better answer is it depends by what the age is, right? So if you see a 7-month-old who's vomiting around the clock, you need to worry about the surgical abdomen in a 7-month-old. The most common cause of surgical abdomen in a 7-month-old is interception. The most common cause of surgical abdomen in a teenager would be appendicitis, absolutely. The most common cause of surgical abdomen in a 2-month-old would be malrotation with valvulus. So you got to know a lot of different epidemiology. And I think that's the biggest difference between pediatric emergency medicine and general emergency medicine, because when you say general emergency medicine and you refer to adults, it's very homogeneous. But in kids, every age is very, very different.
Yes, that makes pediatrics sound like its own unique, fun challenge. I do have a question about pediatric emergency medicine. Can you be a part of that field from the emergency medicine or pediatrician residency route, or do you need to pick one first?
So that's a very good question. So you can become a pediatric emergency medicine physician in the US via two ways, maybe third way sometimes, but you have to do residency either in pediatrics or residency in emergency medicine, and then the fellowship in pediatric emergency medicine. And that's the most common route people go. If you go the pediatric route, the way I did, your fellowship is 3 years long. So residency of 3 years, fellowship of 3 years. If you're doing emergency medicine residency first, your fellowship in pediatric emergency medicine is only 2 years long. And that has to do with the research, because in fellowship, you have to do research. If you did residency in emergency medicine, you already did research in emergency medicine, so your fellowship is a year shorter. I think the biggest advice I tell people who are interested in pediatric emergency medicine is, and that's the advice I got, and that's one of the reasons I chose to do pediatric first, beside the fact that I wanted to work with kids, is decide what would you prefer to be if for some reason you don't go to a fellowship. So I knew that if for some reason fellowship doesn't work, I would prefer to be a general pediatrician than a general emergency physician. So I invested another year fellowship because I knew that if, God forbid, for whatever reason, I don't go or don't get accepted for fellowship, which, by the way, is officially the most competitive fellowship in pediatrics now. Pediatric emergency medicine is the most. I just heard that from our residents who are applying. I knew that I would prefer to be a general pediatrician than a general emergency physician. So I opt for going the pediatric route, even though it's a year longer. I was already older because of the military service. I already had 3 kids, but it's a 1-year investment, which I thought would be no big deal.
Can you tell us a little bit about maybe like a memorable experience or just something that comes to your mind about your residency or your fellowship, like something that you took from it that maybe you use every day or you just remember and like to think about or something?
A specific event?
Sure. Or if that's too challenging off the top of your head, I guess the rules, your podcast kind of explains quite a bit of them actually.
Yeah.
Um,
I think one of my first memories of the pediatric emergency department as a resident was when I was an overnight resident and I was called um, to the pediatric emergency department because they were running a code on a newborn, and it was the very early morning. So when you hear that they're running a code in a baby on a newborn in the early morning, you already know it's most likely a SIDS case. And unfortunately, those babies often come to the hospital already dead. Um, and they were running the code for like 20, 30 minutes. And at some point, the doctor, which I completely agreed, said something to the extent, and it's one of my rules I talk to the podcast. Okay, guys, we have done X, Y, Z for the patient. We have done this and this and this. Can anybody think of what else we can do for this baby? Which I think is probably the best way to end every resuscitation, because sometimes I don't think of something and maybe my nurse did or another physician did, and there was silence. Um, and then he said he called out the time of death, and he immediately went to the mother. And I think that was a very inspiring moment for me, as again, because I knew I wanted to do pediatric emergency medicine. He ran the code very smoothly. He was very humble to say in the end, can anybody else think about what we can do for this baby? So he exhausted his resources.
mhm.
He asked for advice. And then when all failed, his attention was directly to the mother, who
Wow.
obviously needed that. I think that was a very inspiring moment for me as a future pediatric emergency medicine physician.
It also shows that the way he kind of went towards his team, that there was no ego involved. He had a job to do, and he made sure it was done.
Exactly.
Um, I could see how that could be quite memorable for you.
Yeah. And that's actually one of the rules I talk about in my podcast is end every resuscitation with advice. So recognize that you are not the end all be all and you don't know everything and you can forget. And it's totally okay, especially for the sake of helping an ill appearing child, to ask for help, including from nurses or residents. A lot of times my nurses come up with ideas that I didn't think about, or my residents, and it's for the sake of the patient, it's, welcome, should be welcome.
Mm-hmm.
Are there no, that was incredible. Thank you for sharing that with us. Um Adding on to that, are there any particular, so having a lot of emotional awareness is obviously key, especially with working with children, as you described in this experience. Are there any particular skills or qualities students can work on to prepare for those types of experiences and the many others that come along with pediatric emergency medicine? Or are there things that are just kind of innate that, you kind of know it, you kind of know who you are type of thing, and that's that?
I think pediatric emergency medicine, for the most part, is it's a very learnable, teachable field. And that's exactly why I started the podcast, because I wanted students and residents to listen to that and learn what I learned from my mentors. Is really, I think of it as a fairly simple field. I don't think you need any natural skills. Most of the time when I interview residents, I just kind of get a sense that they are hardworking individuals and are passionate about what they're going to do. Um, I think there's certain skills that you can absolutely learn that can really help you. So, for example, again, I talk about in my podcast, a good ER doctor is always ready, be a step ahead. So, and that's a very learnable skill. When you see 5 patients with the same etiology and the same disease, you can kind of predict what's going to happen and be prepared for it. Um, I think efficiency, which is a great skill for an emergency physician, comes with time. So I think for the most part, like I said, it's a fairly learnable, teachable skills and teachable field. Sorry, and you can just get better by seeing a lot of patients, and that's another one of my rules that I talk about. To be a good ER doctor, you got to see a lot of patients. There's really no magic in it.
Mhm.
So where or when along your career do you think you developed the kind of the ability to keep calm in a very stressful situation like the emergency room when maybe like you're running a code or something like that? How did you develop that? And yeah, how did you develop that?
So again, I think Daniel, it goes back to seeing a lot of patients. So I often tell the residents um, when they come out of the room and they describe a patient with a common cold, and they give me the differential, and then I go check the kid, and I agree with them, and I said, "How did you know the kid has a common cold?" So they often say something like, "Well, I know because I've seen a common cold like 20 times," and I said, "That's great. Now you got to see mild asthma 20 times to recognize mild asthma and know what to do. Moderate asthma 20 times to recognize moderate asthma and know what to do. And the same for severe asthma." So again, to be a good ER doctor, you got to see a lot of patients. And to answer your question, I didn't know what to do the first time I saw a code. I had no idea what to do. But you learn as a trainee, and you have the privilege of being a trainee, and being a trainee is a excellent opportunity to learn. That's what it's all about. One resuscitation, two resuscitation, three resuscitations, then resuscitations as a fellow when you're more in charge. And before you know it, you're ready to run a code on your own because you got very good training and you saw a lot of patients. So again, I don't think there's a lot of magic into it. It's just all about practice and repetition, like many other things in life.
Mm,
Just like playing the guitar.
that's right. What are some, I think you kind of touched on this a little bit, but what are some of the most unique aspects, in your opinion, that are in your field that are some of your favorite things to do and look forward to that no other field has but pediatric emergency medicine? What would you say that would be for you?
I think what I like about my field and what's unique to that, and maybe to general pediatrics as well, is again what I speak about in my podcast. I call it rule number 4: less is more. In my emergency department, and again, it's an emergency department, as an emergency physician, most of the time, I don't do anything for the kids. The kids are fine. I just kind of talk the parents off a ledge, and I explain to the parents what to watch for and what to do at home, which is oftentimes just observe. And uh, I think that's a very unique field or unique characteristic for pediatric and even pediatric emergency medicine, because most kids are really fine. And most of the time, when I see a patient in the pediatric emergency medicine department, is because mom or dad misinterpreted a normal behavior as pathological, most commonly fever. So fever scares a lot of parents, but fever is not only normal, is beneficial. And those are the kids that I see in the pediatric emergency department most of the time. And that's why I tell the residents and I tell the medical student, less is more. Sometimes the less you do, the better. And I think that's a fairly unique um, characteristic of pediatric emergency medicine because, again, the kids are really okay. You just have to recognize when they're not, which is the minority of the time. And you got to make sure you give good anticipatory guidance just in case you're missing something. So when I see a kid with abdominal pain, by far I don't work up most kids for abdominal pain with abdominal pain for appendicitis, but I make sure the parents know exactly what to watch for and what to come back for.
Wow, thank you for that. Are there any particular things you feel that, I mean, if you wish you could change about your field?
Um, yeah, so there's one thing that I really wish I could change. It's unfortunately above and beyond me, and this has to do with my work with the emergency medicine residency. Um, and what I know almost for a fact is that in most emergency medicine residencies, you spend about 1 month a year in the pediatric emergency department, which I think is very unfortunate because if you think about it, 3 months out of 36 years is less than 10%. And so you spend less than 10% taking care of children in the pediatric emergency department. But then when you go to your community, in most emergency department, about 20% of the patients are pediatrics. And if you think about it, 20%, that means you have to spend 6 months in the pediatric emergency medicine department in residency. And that I don't think that happens in any emergency medicine residency. So if I could change one thing, is probably increase the amount of time emergency medicine residents spend in the pediatric ER.
Interesting. Do you know why some emergency medicine residencies are 4 years and some are 3? And is that changing or?
That's a great question. I don't know what the reason for that is. And it's very puzzling actually, because it's almost telling the 3-year people you're not qualified enough for the 4-year, the 4-year programs that they're overqualified. I'm not sure why that ever happened. I've worked with residents from both programs. As a fellow, we worked with one of our 4-year programs. I think most of the 4-year programs are DO programs, and maybe that is to do with the osteopathic part of it, because they have to learn some of those skills as well, I'm guessing.
Okay, interesting. So back what you talked about before with the story you gave us, how do you handle emotionally when you see very sick children, almost on a daily basis? I'm sure that can kind of weigh down on you after a while. What do you do to help yourself mentally to avoid any sort of breakdown or anything like that?
That's a very, very good question. I think with time, and that you can say maybe that's unfortunate, but I think with time, when you do this almost every day, you become a little bit more resistant to the emotional aspect of it. It certainly is more challenging when you have your own kids, definitely. But I think with time, because again, you do it every day, and you see so many sick kids fairly often, not majority of the time, like I said, I think you become a little bit more resistant to it. And one can say that's unfortunate. I don't necessarily disagree. Um, but again, one of the things I discuss in my podcast also is, especially as an emergency physician, but as any physician, you better find something you like and enjoy doing outside of medicine.
Mhm.
And it's probably a very good idea to be very engaged in it to the best you can. So for me, it's music. Um, I also have my kids and my family, which is, something that occupies me and, uplifts me and whatnot. But I think it's very, very important to take care of yourself before you take care of others. That's one of my rules. You got to take care of yourself before you take care of others. And that is mentally, physically, diet, exercise, fun, friends, etc. Um, Emergency medicine in general and medicine in general, especially nowadays, as you can see with COVID, can be very, very difficult to do on a daily basis, can be very challenging, can be mentally exhausting. Um, so I think it's very important that early on you recognize that and do something that engages you outside of medicine. For me, it's also teaching. So I got to tell you, I'm a lot more exhausted after a shift that I just see patients on my own, which is not common. Usually, I have a resident or a student that keep me engaged, interested, make the shift more interesting. So that's another advice I give residents very often. My advice to all of us who go into medicine is to pursue some uh, academic lifestyle or career, because I think it makes medicine a lot more interesting when you get to teach someone else and you learn yourself in that process also.
Some of my favorite rotations so far, it's been with doctors that really enjoy teaching, because yes, you're learning, and yes, they're drilling you on like different facts, or like what to do next, this, that, and the other thing. But in a way, it's like you're just hanging out with your friends. You're hanging out with your friends doing a job. So it's less of a job, if that makes any sense.
Yeah, no, I completely agree. Um, every once in a while, I enjoy having a shift on my own, but generally speaking, I really love having the residents, the med students, or the PA students. Again, I think it keeps me engaged. It keeps me on my toes. A lot of times they ask me questions, and I'm not sure. We look it up together, so I learn. Um, and I think it's something that we're all really are committed as physicians. So physicians are really teachers by definition. There will be no future doctors if we don't teach medical students or if we don't encourage people to go to med school. So I think it's part of our responsibility as physicians to teach the next generation. It's also in our best interest because one day we're going to be old, we're going to need doctors. So
Mhm. Yeah, Charlie mentioned to us that when he worked with you, it was very evident and very obvious that you had a passion for teaching and mentoring. Do you know where you got that? Did you pick that up from some of your mentors along the way, or did?
yeah. Um, so I think definitely one of the things that inspired me to be a good teacher is having good teachers. I was very, very fortunate to have excellent mentors and teachers throughout the way who were always very dedicated and encouraging. And again, that's why I try to do the same for others. And when people thank me, when medical students and residents often thank me, I ask them, I appreciate your gratitude and your recognition, but uh, the best thing you can do is just when you get older, do the same for others.
Mhm.
So when you are a 40-year-old physician and a medical student is asking you a question, take the time to explain, uh, try to mentor other residents and inspire them. And again, I think it's really a commitment that we all have as physicians.
Mhm.
Have you been able to practice emergency medicine in different environments, like rural, urban, mid-sized cities? Have you been able to see it in different contexts?
Yeah, a little bit. So I currently work in two sites. One of them is in downtown Orlando in the Children's Hospital, where the acuity is fairly high. We have kids with, you know, liver transplant and hem-onc kids who are very sick. And one of them is further away in the community, where the acuity is much lower. It's also a very different population. But that's pretty much it. I've never gone to any other countries for missions or practice medicine anywhere else.
How different are they in terms of your ability to adapt to both settings and care for the patients?
I think with good training, and I considered my training very good. I really, like I said, I was very lucky to match in a very good fellowship and very good residency. Um, I think good training prepares you for everything you need. So I came out of fellowship very comfortable, working in with the sickest kids in the most high acuity and busy ER. Certainly, I can adapt to see lower acuity, and higher volume as well. So I think where you do residency and where you do fellowship, especially, goes with you forever. And it's something that I was very privileged to have. So.
It's wonderful.
For pediatric emergency medicine, what kind of different work environments can you get a job at? Are you kind of limited to just emergency rooms, or is there any other sort of environment where you can work?
It's a very, very good question, Danielle. And this is goes back to how you became a pediatric emergency physician. So, and that's another reason I went through the general pediatric route. And so basically, when you're a pediatric emergency doctor, you have, by definition, two board certifications. For me, it's general pediatrics and pediatric emergency medicine. For some of my colleagues, it's emergency medicine and pediatric emergency medicine. So someone like me, and again, that's one of the reasons I chose that path. When I'm older and tired, I can always practice general pediatrics, pick up some shifts in urgent care or maybe even general pediatric clinic, because I still have my certification and I am maintaining my certification in general pediatrics. If you did emergency medicine residency and then pediatric emergency medicine fellowship, you are limited to the field of emergency medicine. So you can work in a general emergency department, you can work in a pediatric emergency department, you can work in urgent care probably, but that's pretty much it. And that's another advice I give the residents. If you are going into the field of emergency medicine, I highly recommend early on to find something else other than medicine or emergency medicine to be engaged with and possibly make money of. It is very challenging to practice emergency medicine or pediatric emergency medicine full time as you get older. So for me, it's academia. I get paid to teach, and that buys me some time out of the emergency department, which I love, but it gives me some less challenging or less intense work. I enjoy teaching. I enjoy giving lectures. For some people, it's administration. So some of us go to emergency medicine and learn how to be facility medical directors or assistant directors. So it's very, very important. And you got to recognize that early on, and you got to work on that early on. So even in my fellowship, I started be very involved in academia because I knew that one day I want to teach for a living, or at least partially.
And you mentioned that you're gonna, you either did start or you're about to start teaching a pathophysiology course.
Right. So a few months ago, I was recruited by Advent Health University, which is the university associated with my hospital, Advent Health for Children. And I started teaching general pediatrics there. And we had good interaction. The PA students were very happy. And they called me to start teaching pathophysiology because pathophysiology professor, I'm not sure what happened there. And I started teaching cardiovascular pathophysiology, which made me very humble. I had to go back and buy step one books and relearn cardiovascular physiology. Next semester, I will be teaching renal pathophysiology. So again, I have to learn about hypertension and all those things in adult medicine that I haven't seen in many years. And the following semester, I will be teaching OB pathophysiology, which is again not a whole very small component, but a very small part of what I do for a living. So it was a very good and humbling experience to kind of go back to the books and relearn some of medical school.
Mm-hmm.
Yeah.
When
Remember
you,
Laplace's law in cardiovascular physiology?
Yeah.
Yeah, I had to go back and learn it.
And I was just wondering, I think you've touched on this as well, but any particular turning point moments or challenges that you overcame that you'd like to share with us, and any wisdom or advice from those challenges?
I think one of the biggest challenges in fellowship was my first overnight as an attending. So in fellowship, sometime I think halfway through fellowship, we started doing attending shifts, where basically you work as the attending, which is not particularly challenging during the day because you have other attendings to help you out. But I think my first overnight as a fellow in an attending shift was a very big milestone. I don't think it ended up being challenging, but it was very sort of intimidating because from I think 4 a.m. to 7 a.m., I was the only attending at a very big children's hospital where teenagers walked in stabbed or overdosed or sometimes unfortunately dead. So I think that was a very big turning point and sort of an intimidating aspect of my career. But again, with experience, you get there and you know what you need to do. So
wow, I can imagine that feeling being pretty scary a little bit.
well, it's the same feeling you have. I mean, I think we all go through it um, when you finish residency. So when you finish residency, now you are the attending. Um, and that's one of the reasons I recommend for fellowship for residents to do a fellowship, because I think it offers you a transition from being a resident to being an attending. I can see how it's very challenging and definitely very intimidating to do 3 years of training only, which is, it's not as much as you think. It goes by very quickly, and then become the attending. I think fellowship, in a way, is easier because it gives you that transitional 2 or 3 years between being the trainee to being the person who makes the call.
Mm-hmm. So how are you involved with the residency program at your hospital?
So currently, I sit as faculty in the emergency medicine residency. So in most or in almost all emergency medicine residencies, there's at least one pediatric emergency medicine qualified individual. So that is me for our program. I also do a lot of teaching. I did a suturing class today with the pediatric residency. I teach the family medicine residents who come into our hospital for the Pediatric Emergency Medicine rotation. And I often teach the students who rotate through our emergency department in the classroom and obviously by the bedside. And then, like I said, recently I started teaching basic sciences at Advent Health University.
Interesting. Okay. When you're given a student to teach, are they assigned to you for the whole month, or are they assigned to the emergency department and then they just grab onto an attending for the day, or how does that work in certain, I guess, in your hospital?
So in my hospital, usually we have one or two students every month. That student is just in the pediatric emergency department, and there is only one attending at any given time. So basically, it's you, the resident, and the student. I often try to encourage the resident to do at least some of the teaching, because, like I said, I want my residents to learn how to teach. I think it's important to teach, and I think it's very good for you to teach as a physician. And I try to intervene as little as I can to let the resident be the teacher for the student. And sometimes when it's very busy, I take the student on my own. I see patients with them, certainly teach them suturing and some other skills.
What particular? Sorry, go ahead.
You first, Raj.
So when you're teaching your residents and your other students, like what, I guess day one, what is like some of the first things you tell them in terms of like how to approach their patients? You know, do you do a step-by-step approach, or do you like what are some of the things that you do to kind of guide them through on their first day?
Do you give them a handout of your rules?
I don't, so that's exactly why I started the podcast, because what I want, so when students, I feel like when students listen to my podcast before they come in, they come a lot more prepared. And you mentioned about what's the most important thing I teach them, or what's the first thing I teach them. The first thing I teach them is pediatric emergency medicine rule number 1. It's not the patient's job to prove that they're sick. It's your job to prove that they're not. And this is, to me, the hallmark of emergency medicine or pediatric emergency medicine. Patient comes in with abdominal pain. My primary job today, other than stabilizing him, they usually are stable, is to make sure this abdominal pain is not surgical, it's not serious, it's not life-threatening, and the kid is going to be fine. And I think that's what a lot of students and sometimes residents, especially the pediatric residents and the family medicine residents, struggle with. I'm not in the business of making a diagnosis. I'm definitely in the business of ruling things out. So rule number 1, it's not the patient's job to prove that they're sick, it's your job to prove that they're not, is the first thing I teach them. And then I teach them in the pediatric emergency department, I'm not in the business of winning, I just don't want to lose. So if I send a child home with abdominal pain and it turns out that he has appendicitis, I lost. That's a lose. I don't need to win. If he comes in with abdominal pain and he has abdominal migraine or some other benign etiology of abdominal pain, I don't need to know that. But I better know, better know that it's not surgical. For example, appendicitis comes to mind, or that vomiting is not intussusception, etc., etc. I'm in the business of ruling things out.
That's very interesting.
For the residents, especially the pediatric residents and the family medicine residents, that is somewhat of a challenge, because general pediatricians and family physicians are diagnosticians. They think diagnostically. They think of, I need to find the problem. I don't need to find the problem. In emergency medicine, I need to rule out the bad ones. That's all. Simple.
That's very interesting. I feel like that also, puts you more on, like the patient side and allowing you to really think, on from their perspective and empathize as well. I think that's a very interesting mindset to have to build.
Yeah, I mean, I think you're right, Raj, but unfortunately, because the way medicine is in the US, a lot of times parents come to the ER with the notion that today we're going to find the problem. And that is something that I try to, again, I talk about it in my podcast, set up the expectations. When you come to the ER with abdominal pain for the last 9 months, I'm probably not going to find the problem today. So abdominal pain for 9 months, by definition, is not an emergency. I'm an emergency physician. I don't know so much about chronic abdominal pain. In fact, I don't know anything about chronic abdominal pain anymore. But I know almost everything about acute abdominal pain and surgical abdomen. So I think it's very important. That's why I said to some parents and teach the medical students and talk about it in my podcast, you got to set up the expectations. So abdominal pain for 9 months, mom. We're going to do some blood tests. We're definitely going to help you out if you're worried. We're going to send you to the GI doctor. I just want to make sure you know I'm probably not going to find out why little Johnny is having abdominal pain for the last 9 months. We're going to try. We're going to do our best.
It's also knowing what you know and staying within proper parameters to make sure you're not, overstepping out of your knowledge boundaries or anything like that as well. And
Correct.
that's really amazing.
You'll be amazed, guys, when you start practicing medicine, how quickly you forget a lot of med school. So you start doing pediatrics, you forget everything about OBGYN and internal medicine, and you become a pediatric pulmonologist. You do asthma so much, you forget everything about the kidneys and the PICU and all that stuff. You forget a lot quicker than you think.
As I was listening to one of the episodes of your podcast recently, I had never thought about this before, but it was interesting how you said that sometimes you don't actually get a lot of information about a physical exam, especially on a young crying baby, just because they're crying, they're not easy to exam. You might not be able to hear the findings 100%, and how important the history is. I found that kind of interesting.
Yeah, so that's something that I always have a hard time teaching students, because I feel like it can easily come across as physical exam is not important, which is not what I try to teach.
Right.
But in pediatric and pediatric emergency medicine, Daniel, there actually been studies how the HPI is by far the most important part of the encounter. And I give several examples in the podcast, but if I always teach the resident, get a good story. You can diagnose many or rule out a lot of what we see in the pediatric emergency department with a very good HPI. Now, obviously, in some newborns, the HPI is crucial. And again, I don't want to discourage any students who are listening from doing physical exam, but let's be honest. In a crying child, you can't hear the lungs. In a crying child who's straining, you can't feel the abdomen. And I think it's also very important that we're honest. In the United States 2021, you're not going to diagnose pneumonia with a physical exam. That's almost inappropriate. You get a chest x-ray. It's not fair for the child to be condemned for 10 days of antibiotics without a chest x-ray. That's why would we do that? So again, physical exam, very important. It's a big component of what you guys do as medical students, but I think it's also very important to be realistic. 2021, United States, you got to rely on some blood tests and some imaging studies, which is fine. Those are readily available to us. And I can't tell you how many times I made a diagnosis just by a good story. Just the history taking skills is the most important thing of what I do.
Would you like to tell us why you started your podcast, when you started the podcast? I know that's not an easy thing to do when you're a full-time attending teacher and physician. How did that become a project of yours?
So, like I said, I've always been very, very passionate about teaching. And when I get students in the pediatric ER or residents, I find myself teaching the same principles again and again. One day I came across a colleague, a new colleague who was recruited to our emergency medicine residency program by the name of Andy Little. And he already had a podcast, a very successful podcast called EM Over Easy with two of his friends. And he inspired me to do this. Just so it happens, because I do and record so much music, I had all the equipment already at home, the microphone, the acoustic room that I have. So that part was very easy. I know how to work out I know how to work with GarageBand, and I had so much material I wanted to teach. It was actually fairly easy to do. You go online, find out how to go through the process. I got a book or two. And again, the biggest, I think, limitations are the technical aspect, which was not a problem, and the content, which also was not a problem because I had so much of it. And it's been a lot of fun. Choosing a name, I don't know if you guys experienced that, but choosing a name was a big deal, right? That was one of the biggest challenges. A name and a logo, right? But I had my brother-in-law who helped me. And it's been, I gotta say, it's been almost a year. It's going to be a year in coming January. Uh, Great experience. Helped me teach, all the way abroad because I get some listeners from all over the world. It's been a lot of fun. And I do all the music. I don't know if you noticed, I do all the music in the podcast.
And it seems
Except for
definitely
the drums. The drums
outro
is garage band, but
Yeah, the music's good. I've been listening to quite a few of them the last couple of days. As I've listened to some of them once before, like 6 or 8 months ago, but I've been listening to a lot of them the last couple of days as I refresh for this interview.
thank
And
you.
it's good. It's got me excited again about medicine. Sometimes as you study for a long time and you're just hitting the books all the time, you need to remember your why. And just like putting myself in some of the situations that you talk about in your podcast, just it's a lot of fun.
I'm glad. I was in the same manner. I hope I inspire you to play some music and pick up an instrument.
Mhm.
If you want to borrow one, I have 24 guitars. Just pick one.
Yep.
Adding on to that, so you talked about your passion for teaching. You have a podcast. You love pediatric medicine, obviously, and one of your inspirations was the pediatrician that you used to go to when you were growing up. Have you had any new inspirations? Have your inspirations changed over time? And what keeps motivating you to do what you do on a day in and day out?
So that's a great question, Raj. And I know it may sound a little corny, but I think some of my biggest inspiration are the residents. So I'm 43 now, getting a little old, getting a little tired, and to work with those super motivated, eager to learn students, residents, I think keeps me so happy and engaged. Um, I think that's one of the biggest drives of my work because I can relate to them and they really inspire me to, work hard, open the books when I don't know, or, going up to date and whatnot. And again, I know it sounds kind of corny, but I think the residents and the young residents and medical students, which I was, not too long ago, really inspired me to be a better physician.
They keep you on your toes.
Keep me on my toes. Absolutely. Sometimes they remind me of things I forget, so it's great.
Mhm.
Yeah.
Remind you of the excitement and the energy because they're kind of seeing it for the first time for them.
Yeah.
So
No,
Yeah.
it really is inspiring. It reminds me of where I came from and what we should all strive to do. And again, it's not easy to do the same thing any field in medicine. To do the same thing again and again is not simple. It's not easy. It can wear you out. But the students and the residents make it more interesting, more engaging, and more fun. I encourage all of you students out there when you start residency alone can be very, very challenging. And sometimes it's really challenging to add to that some academic activities that you don't have to do. But it's very important. And when you finish residency, I highly encourage you to seek jobs with academic opportunities. Be the teacher that your teachers were to you. Be the mentor that your mentors were for you. Um,
Mhm.
it's sort of like a debt we all have to pay,
Mhm.
in addition to the medical school debt that we have to pay.
Yes. Well,
wow.
thank you. Raj, do you have any more questions?
Um, no, I think that's it for me. Do you have any more questions?
I don't. I do appreciate your time, and we really enjoy your podcast. We had a
Thank
good
you.
time talking to you today. Do you want to tell everyone the name of your podcast and where they can find you?
So you can find my podcast where you find most podcasts on Apple and Spotify. The podcast is called PEM Rules, PEM Rules, Pediatric Emergency Medicine Rules, and there's a website, pemrules.com. I always love getting feedback. You can submit feedback on the website if there's a specific topic people want to hear about. I'm happy to accommodate any requests. The podcast is really about all those rules, so to speak, that I learned as a fellow and as a resident, starting with, like I said, rule number one, it's not the patient's job to prove that they're sick. It's your job to prove that they're not. And as I mentioned, part of the fun, I do all the music. The intro is a piece of music that I wrote as a teenager many years ago, and then the outro is always different. Red Hot Chili Peppers, Nirvana, you name it. A lot of music from the 90s. I grew up in the 90s. So.
It's a good era. It's a good era of music. Thank you so much for speaking with us today. We've learned so much from you, and we really, really appreciate your time. Thank you.
Thank you guys very much. Again, best of luck with your podcast. Keep up the teaching. It's very good. Say hi to Charlie.
Yeah, we will.
Yes, definitely.
Thank you guys.
The Medical Muse is produced by Timothy Crowe. Your hosts are Daniel Epstein and Raj Kavadi. Social media coordinator, Anja van der Osten. Music on the show by Foxy Music. For more information, check out foxymusic.com. Join us next episode for a special joint interview with Dr. Ian Singer and Dr. Athena Hagianidis, President and Vice President of the American College of Osteopathic Family Physicians. Lastly, we'd love to connect with you. Follow us on Instagram at @the_medical_muse or on Twitter @medicalmusepod. See you next time.